Okay, good morning, distinguished Professor Yahaya, dear colleagues, ladies and gentlemen. Welcome to the session on recent advance in CTO and complex coronary intervention. And I'm here from the first affiliated hospital, Harbin Medical University. And it's really my great honor to chair the session with distinguished Professor Yahaya. And Professor Yahaya is from the Hasan Sadikin General Hospital from Indonesia. And he's chairman of Indonesian Society of Interventional Cardiology and vice president of Asia Pacific Society of Cardiology and the national course director of fellowship training program, and also he's my best friends. And other two chairs are Professor Li Yongle from Tianjin Medical University General Hospital and Professor Yu Zaixin from Hainan General Hospital. And today we are joined by four outstanding experts from across the region. And I'm confident their insights will open new horizons and bring fresh inspiration to our daily practice. And let us look forward to a session full of knowledge and lively exchange. Thank you. And Professor Yahaya, please to host the lecture, please.
Okay, thank you very much. Thank you very much, Professor Lee. So on behalf of my fellow moderators, Professor Lee, Professor Yong Lee, and Professor Zainsin Yu, I would like to thanks to everyone for joining us this morning. So this morning program has been carefully designed to cover several of the most relevant topics in contemporary CTO and complex PCI. So we will hear about the expanding role of intravascular imaging, the evolution of the hybrid algorithm, contemporary approach to coronary calcium modifications, and practical strategy to simplify retrograde CTO interventions. We are fortunate to have an outstanding panel of internationally cognizant experts. I'm certain that their presentation will provide not only the latest scientific evidence, but also practical insight that we can immediately apply in our cath lab. So I would like to encourage all participants to actively engage in the discussion. Please take this opportunity to ask questions, share your experience, and exchange ideas with our distinguished faculty. Without further ado, let us begin our scientific program. It is now my great pleasure to invite our first speaker, Dr. Ahmad Kazim, who will present intravascular imaging guided complex PCI lesson from Calypso, Occupy, and Renovate trial. Ladies and gentlemen, please join me in welcoming Dr. Ahmed Kazim.
Thank you, Professor Fauzi. It's my pleasure to share in this summit. Thank you, Organizing Committee of Asian Heart Society. It's my pleasure to share in this summit my talk today about intravascular imaging guided complex PCI lessons from Calypso, Occupy, and Renovate trials. Of course, all the data mentions that complex coronary lesions have worse clinical outcomes than PCI for non-complex coronary lesions, and randomized trials for imaging versus angiographic guided PCI defined complex anatomy as a lesion characteristic associated with recurrent events or stent failure, and it defined this complexity as unprotected left mean, severe calcified lesion, CTO lesion, a true bifurcation lesion with side branch diameter of 2.5 millimeter and more than 50% stenosis within the first 5 millimeter, and long lesion, more than 38 millimeters, multivessel PCI, at least 2 major epicardial arteries treated at the same time, multiple stent lesion that would necessitate use of at least 3 planned stents, ostial lesion of major epicardial coronary artery, or lesion involving stent restenosis. And of course, all of us know that the angiography is the gold standard tool for management of coronary artery disease, but there is significant limitation for this coronary angiography. It is 2D luminograph, so it cannot clearly and accurately judge the underlying pathogenesis and the plaque morphology and the composition of the plaque and the wall, including the most important issue is the calcification, where there is low sensitivity for detection of the calcium by the coronary angiography despite the high post-predictive value. And of course, from the data, we know that the OCT is 10 times had more resolution than other modality, IVAS and virtual histology IVAS, in comparison to this in term of detection, localization, and quantification of the calcium burden, of course. And one important parameters for the OCT that infrared light is not attenuated by calcium as opposed to ultrasound in the IVAS. So OCT uniquely afford ability to measure and characterize the calcium burden, thickness, length, and arc in heavily calcified lesion. And it is clearly and simply we can by OCT detect the calcium scoring if the arc more than 180, 2 points, thickness more than 0.2 millimeter, 0.5 millimeter, 1 point, length more than 5 millimeter, 1 point, score more than 3, mandate the modification strategy, either IVL or atherectomy or excimer laser according to operator preference. This recent data about the lesion stratification by OCT by McGurphy in neurointervention 2026 stratify the risk of the lesion according to OCT finding into low risk and chronic coronary syndrome, including fibrous tissue lesion or sheet of calcium with arc less than 90 degree and small lipid core lesion. While the high risk category by OCT, it is thin cap fibrous stroma with thickness less than 65 micron and high plaque burden, large lipid core, layered pattern of the plaque in terms of subclinical recurrent atherosclerosis, rupture plaque, and healing after that. And also the pattern of acute coronary syndrome, including the plaque rupture, plaque erosion, eruptive calcium nodule with overlying white or red thrombus. So the question for the intracoronary imaging, it should be routine, precision of the intervention, or should be reserved for the complex lesion. Recently, in European guidelines for the chronic coronary syndrome, upgraded the recommendation of the using of imaging, either IVAS or OCT, for complex lesion like left mean stem and true bifurcation and long lesion to be class 1A recommendation. And also, in the same way, the American College of Cardiology, American Heart Association, SCAI for the acute coronary syndrome recommendation in 2025 also upgraded the recommendation from class 2A recommendation to the class 1A for left mean and complex lesion to be used whether IVAS or OCT to reduce the ischemic events. It is actually a long journey for the evidence for supporting intracoronary imaging for complex BCI started 2005 by American recommendation to be class 2A for IVAS use. Then after prospective trial, European recommendation, then coming IVAS XPL and Illumine 3 opinion and ultimate trials, then European involve the OCT in addition to IVAS for class 2 recommendation. Then lastly, the recommendation after Renovate Complex October and Equipe Prevent trials, it is upgraded to class 1A recommendation. So we have growing evidence for supporting use of intracoronary imaging in the complex lesion. And this data from very huge cohort registry, the Pan-London BCI registry, which includes more than 88,000 of patients. Actually, it is showed OCT in this registry associated with procedural outcomes improvement. Of course, this have very significant limitation in this where it is detected clearly that intracoronary imaging in real life registry like this registry, it is underutilized. OCT used only in 1,100 49 patients, which represent 1.3%. IVAS used in 10,971 patients, which represent 12.6%. And the majority of the patients in this registry, 75,000 patients, represent 86%, not using imaging in this registry. So it is actually underutilized in real life. And the explanation, probably it is unfamiliarity with imaging equipment, knowledge gap in image interpretation, perception of increased procedural times adversely affecting workflow efficiently, lack of adequate financial reimbursement, evidence based in need for further definitive trials. And the previous trials like CTO, IVAS, AVIO, IVAS XPL, Ultimate, Home DES, IVAS reported lower rates of major adverse cardiac events following IVAS-guided PCI compared to angiography. But of course, due to the limited sample size, short follow-up duration, and inclusion criteria of highly selected lesion, the results considered not definitive in this studies. Then coming the large landmark trial like Renovate Complex PCI trial and Occupy trial, Calypso trial, which having highlighted the importance of the using of imaging in the complex anatomy lesions. Of course, it is Renovate Complex PCI trial, prospective, multi-center, open-label trial in South Korea. And the study include 1,620 patients with complex coronary artery lesion undergoing PCI, randomization 2-to-1 for treatment of the target lesion, stratified according to acute coronary syndrome, participating centers to image-guided group, including 1,080, and angiographic-guided group, 540 patients. And the complexity criteria in this study, including a definition of complex like true bifurcation, and CTO lesion, unprotected left mean, long stent more than 38 millimeter, multi-vessel PCI, 2 vessel treated in 1 PCI session, and multiple stent needed, 3 or more stent per patient, and stent stenosis, target lesion, severely calcified lesion, and ostial location in the major vessel like LAD, LSX, or RCA. And of course, inclusion criteria, including this complexity criteria, in addition to key exclusion like target lesion not amenable for PCI, cardiogenic shock, intolerance to medication, true anaphylaxis to contrast media, pregnancy, breastfeeding, non-cardiac comorbid condition with life expectancy less than 1 year, and unwillingness or inability to comply with the procedures protocol. The primary endpoints for Renovate Complex, including the target vessel failure at median follow-up 2 years, with significant reduction of target vessel failure in image-guided group 7.7 in comparison to angiographic group 12.3, with p-value very highly significant 0.008. And also the secondary endpoints, target vessel failure excluding procedural MI, show significant differences between both group in favor of image guided. So both primary and secondary endpoints showing significant reduction of target vessel failure, otherwise comparable results. But as regard to the image optimization after stenting, the group of optimal stenting by imaging after imaging show significant reduction of target vessel failure in comparison to the image-guided PCI without stent optimization and angiography-guided PCI 12.3. Also comparing OCT individually with angiography and IVAS individually with angiography, showing the favor of OCT arm in comparison to angiography and IVAS arm in comparison to angiography arm, and also comparing both OCT versus IVAS guided, showing comparable results with no significant differences. So OCT and IVAS can be guided the complex PCI. So in conclusion of the Renovate Complex trial, showed that among patients with complex coronary lesions, intravascular imaging guided PCI improved clinical outcomes as compared to angiography guided PCI, as it led to lower risk of composite of death from cardiac causes, target vessel treated MI, or clinically driven TVR than angiography guided PCI. Then coming this year by Lee and his team in JAC 2026, the 5 years outcomes of Renovate Complex trial, it is the same number of patients, 1,639 patients, and randomized 2-to-1 primary endpoints, target vessel failure, median follow-up 5 years, and the result is significant differences between the image-guided BCI 10.5% and angiography-guided BCI 14.9%, with improvement the outcomes after landmark analysis. It is early benefit observed within the first 2 years was sustained without late catch up after 5 years in this follow-up study. And also as regard to the primary endpoints to the complex lesion, there is subgroup analysis showed that consistent treatment effect across all types of the lesion, including CTO, unprotected left mean, diffuse long lesion more than 38, and severely calcified lesion, osteal stenosis, but it is more clear and particular benefit in CTO lesion and diffuse long lesion. Then also the outcomes had impact in the stent optimization, where image-guided BCI with optimization, it is much better than image-guided BCI without optimization, and also in comparison to angiography-guided BCI, of course, in terms of reduction of target vessel failure in this group. So extended follow-up data demonstrate intravascular guided image BCI provided durable reduction in hard clinical points for a patient with complex coronary artery disease, with benefit persisting through 5 years. And this actually strongly supports the recent guideline upgrading to Class 1A recommendation for using of intravascular imaging in the complex BCI, and reinforces the importance of achieving optimal stent expansion, apposition, edge dissection free results to improve the long-term outcomes. And also pooled analysis from Renovate Complex trial and Samsung Medical Center institutional registry involving more than 4,611 patients with complex anatomy. And of course, after a pooled analysis involve this group of patients, 1,639 from the Renovate Complex and 2,972 from the Samsung Medical Center registry. And of course, they divided into lesion with less complex, less than 3 complex lesion, and another group with 3 or more complex lesion. Then make study for the angiography guided group in both groups in comparison to the imaging guided study. And of course, the results of this pooled analysis showing significantly that target vessel failure according to lesion complexity is much more higher in the more complex lesion, 3 or more complex lesion associated with more target vessel failure. And also the result in comparison to the patient having less than 3 complex lesion, the benefit of image guided is better than the patient with angiographic guided. But this benefit is extended and become more significant when the patient having more complex lesion, more than 3 complex lesion. So image guided more significant reduction of target vessel failure with the severity of the lesion actually. And this actually comparing target vessel failure according to the overall lesion complexity, 1 lesion, 2 lesion, 3 lesion, and it is more significant with 4 lesion or more in terms of incidence, reduction of incidence of target vessel failure with the increased number of complex lesion features. And this analysis showing that intravascular imaging guided demonstrate low risk of target vessel failure across all degree of lesion complexity, and the benefit of image guided BCI tended to increase as the patient had higher number of complex lesion features actually. Then coming the OKB randomized clinical trial, which actually very important data published in Lancet 2024 from South Korea, where the clinical benefits of OCT guided BCI versus angiography guided BCI in complex lesion assessed by rate of major adverse cardiac events after 1 year. It is a multi-center randomized open label superiority trial and the 1,604 patient with complex lesion randomized to one randomization, OCT group 803 and angiography group 801. Then inclusion criteria including patient 19 to 85 and patient with ischemic heart disease, stable or unstable or MI, and complex coronary stenotic lesion, nearly the same criteria like Renovate. Exclusion criteria: severe hepatic dysfunction, significant renal dysfunction, hematology abnormality, and hemodynamic instability and shock state, or LV ejection fraction less than 30%. And OCT group, of course, underwent pre-stent OCT assessment and post-stent recommendation and optimization with co-registration. Actually, during the study, the primary endpoints are major adverse cardiac events at 1 year in terms of MACE, composite of cardiac death, myocardial infarction, stent thrombosis, ischemia-driven target vessel revascularization, and secondary endpoints, individual component of primary endpoints, target lesion revascularization or any revascularization, stent optimization confirmed by the post-stent OCT, and contrast-induced nephropathy. The baseline characteristic actually did not differ between both groups, and the lesion characteristics also did not differ between both group OCT guidance and angiography guidance. Then procedural characteristics were stent diameter, high pressure post dilatation, maximal inflation, atmospheric pressure, and the post-procedural minimal human diameter much more higher in the OCT guidance group in comparison to angiography group, with very high significant results actually. ECOB results showing the result significant reduction of OCT in terms of MACE, composite cardiac death, MI, stent thrombosis, and TVR at 20 years. Then ECOB coming with secondary endpoints, the same results with reduction of spontaneous MI and target vessel related MI and TVR and target lesion revascularization in the OCT guided group in comparison to the angiography guided group. Also, stent optimization, which is show significant reduction of
可以啊，你自己买的算便宜些不了。
或者你在店子买一样的，可以啊。
那就不开是吧？
Okay, please proceed, Dr. Kasim.
Yes, OKB conclusion, OCT guidance result in lower incidence of 1 year composite cardiac death, and the findings support the therapeutic benefit of OCT. Then post hoc analysis of OKB showing that in relation to lesion length and vessel length, where the QCA analysis according to lesion length more than 32 or less than 32, and diameter more than 2.8 millimeter or less than 2.8 millimeters, with significant reduction of the MACE in image-guided group in the lesion more than 32 and lesion less than 2.8 millimeters in diameters. And of course, the incidence of 1 year MACE much more significant reduction in the OCT-guided group according to this study, where OQB trial showed direct effect of favor OCT-guided complex BCI in comparison to the angiography-guided for lesion length and vessel diameter, especially length more than 32 and diameter less than 2.8. Then coming the Calypso trial, which is actually OCT guided study in France, prospective multicenter open label randomized, including more than 134 patients to guide the calcium. Of course, the design patient with significant moderate to severe calcified target lesion by angiography 1-to-1 randomization, and quantifying the primary endpoints, post BCI minimal stent area on final OCT, and secondary endpoints, of course, the choice of plaque preparation modality based on the maximal arc of the calcium and OCT. If it is extension less than 180, it is NSC alone only. Extension 180 to 270 IVL NSC alone. Extension more than 270 rotablation can be used, and IVL according to the operator preferences. And baseline characteristic is comparison similar in both groups, and also the QCA analysis showed comparable results. Procedural characteristics showing significant use of intravascular lithotripsy in the group of OCT guided PCI then procedural characteristics showing no differences in terms of contrast use, procedural time, radiation dose between OCT groups and the angio-guided group. Then the final post-BCI analysis, the minimal stent area is much more higher in the OCT-guided group with very highly significant p-value, of course, 6.5 in comparison to 5 millimeters squared, and also the major malposition length, it is much more less in the OCT guided group. Primary endpoints, minimal stent area in the OCT guided group, very highly significant increase in comparison to and the secondary safety endpoints, no differences in terms of procedural complication, contrast medium volume, and the procedural time. And the conclusion of Calypso randomized clinical trial, OCT guided BCI strategy according to pre-specified algorithm conferred better stent expansion compared to conventional angiographic guidance, especially in moderate to severe calcified lesion without any additional safety concern, whether this superiority in terms of imaging guided endpoints translated into clinical benefit actually needed to be confirmed in the future. Just a few minutes to review a very complex case here. A young patient, 33 years old, heavy cigarette smoker, having chest pain, went to private sector here in our city and underwent angiography, but they failed to open the right coronary artery. Patient having non-STEMI on presentation to private sector. They failed to open RCA, they referred to our center. Once patient coming to our center, still having the ECG and enzyme criteria of non-STEMI and still having pain. After discussion, her team, we decided to go for a second trial, and left system show no significant lesion, right system filled retrogradely by collaterals from the left system, and this is the RCA showing total occlusion from mid segment, but there is filling defect approximately. We don't know, is it thrombus, is it dissection, spiral dissection? So we try to open with PMW wire initially, but the wire buckled and cannot be advanced. We need use support, it is also failed, and we using the dual injection technique, CTO technique, for guidance of crossing of this very long segment of total occlusion of this RCA, actually with use of parallel wire technique. The Felder FC wire eventually successfully cross this long lesion actually. But the question for us after we cross this very long segment of RCA total occlusion, what is the underlying pathogenesis? We don't know. This is the dissection or thrombus. So we use intracoronary imaging, OCT, actually, which showed clearly it is not dissection, it is thrombus and lipid-rich plaques with red thrombus filling the lumen of the artery. So we deploy 3 stent after measurement, and we use 3 by 38, 3.5, and 3.5, 30, and 30.26 from distal to proximal, and this is the final results. It is excellent angiographically, but it is not reliable to make final decision of optimization in this complex lesion with long segment and large burden of the plaques. So we repeated again the OCT after stent deployment. It is a big surprise. It is suboptimal angiography actually, and there is large plaque burden, large thrombus burden jailed by the stent, which actually need us for later on onset malabsorption, because this resorption of the large burden of the thrombus can causing late onset acquired malabsorption in such cases, and also the tissue prolapse and the thrombus prolapse in some parts clearly seen by the OCT, which is actually debatable to have impact, and also major under expansion in some area of the stent, and this area was localized malabsorption in this segment. So it is clear from 3D format there is red color stenting here, which is signifying clearly there is area of malabsorption and under expansion. So we make optimization by larger NEC balloon 4 by 15 all through from distal to proximal, and this is the final results after optimization, and OCT showing well opposing of the stent. All are white colors according to the 3D formats, and well opposed stent clearly seen here from this 3D reformats. Patient went home after 3 days from CCU and coming to us after 6 months by atypical chest pain. We insisted to do angiography to assess the previous stent. It is patent stent actually after 6 months without any major adverse cardiac events or target vessel failure or any stent stenosis in this very long lesion complex anatomy patient. So my final conclusion, utilization of intracoronary imaging to guide complex PCI remains low despite increasing evidence supporting improving clinical outcomes by using intravascular imaging to guide complex PCI. Both IVAS and OCT guided PCI provide comparable short and long-term benefits on stent expansion, MACE, revascularization, and stent thrombosis. The choice between IVAS or OCT should be based on the operator expertise, availability in the cath lab, patient characteristics, clinical scenarios, especially lesion length or location, and OCT is a gold standard tool for superficial layers like ACS cases with vulnerable plaques, plaque rupture, erosion, calcium nodule, heavily calcified long lesion, bifurcation lesion, unstable SCAD, thrombus type, red or white, can easily discriminated by OCT, and IVAS also important tool for ostial left mean, CTO lesion, long lesion, bifurcation, deep calcium, and chronic kidney disease. When compared with IVAS, OCT demonstrated more accurate estimation of calcium thickness and the plaque morphology, and many studies demonstrated superior precision of OCT in evaluating post-PCI residual dissection, plaque prolapse, incomplete stent apposition, and stent coverage over time compared to standard IVAS with 30 or 40 megahertz. Thank you for your attention.
Impressive and comprehensive presentation, Dr. Kasim. Your case is fantastic as well. So I'm sure there are many comments and questions regarding the role of intracoronary imaging, especially OCT in guiding the PCI. Consider we already behind the schedule. We will have discussion after all the speakers' presentation. So I invite Dr. Lee Songs to present the hybrid algorithm in 2025, integrate versus retrograde strategies and declining role of ADR. Dr. Lee Song is from Huai Hospital, Chinese Academy of Medical Science. So the time is yours, Dr. Lee Songs.
Thank you,
Thank you.
Professor. Good morning, everyone. I will share my slide. Okay. Today, my topic is the CTO hybrid algorithm in 2026 and integrate and with retrograde strategy and the decline role of the ADR. And Dr. Song, I have nothing to disclose. And as we know, in the last decades, globally, we have published 6 algorithms across the world. Include the first algorithm is hybrid algorithm and published in 2012, and after that is Euro CTO algorithm and China CTO Club CTO-CC algorithm, Japan CTO Club algorithm, and AP Asian Pacific algorithm. And in 2021, we also published global CTO crossing algorithm. After a decade of the hybrid algorithm, and is this currently the time to resequence the algorithm depending on the improvement of this field, and because in fact the success rate have plateaued in complex anatomy despite mature algorithm and multiple increment in improvement in the device, including more than 100 dedicated wires. And the improvement of the imaging guidance is now routinely and ever so we define the proximal cap, the wire position, and the entry target. Integrated toolbox has widened well beyond the simple wire escalation, including a lot of improvement technique of the integrate approach, including the ATS, the HDR, and the TDADR, and something etc. And conventional device supported ADR, like the steering wheel and the crossbars, and no longer sits comfortably as a primary pillar from my thought. And the classic hybrid algorithm in 2012 is first published in JACC Intervention and by Brailovskis. And this is the original published version, and I think it's very simple and clearly. It's based on the three anatomic questions, including the proximal cap is ambiguous and distal vessel and landing zone is good. And if the patient have acceptable interventional collateral, we can use. And but what after the targets, what carries in 2026? And the four strategy persist, including the AWE, ADR, AWE, and RDR. And the three questions persist, including the proximal cap, distal target, interventional collaterals also there. And what's the sequence is the order of the preference within the integrated approach, and the threshold for what time, what's the appropriate time for the retrograde to start. And the dissection entry and also different is split into conventional ADR and with the contemporary ADR. I believe the contemporary ADR is to limit the length of the subintimal segment. And the hybrid strategy switching also important. It more emphasis in imaging derived rather than the time or the length derived alone. And we published a lot of algorithm, including the EuroCTO, APCTO, and CTO-CC. And these three algorithm also emphasize the importance of the imaging, not only the angio, bilateral angio, and CT scan, and iris. And what has changed after this decade? And with the help, we have to emphasize the importance of the CT scan before this procedure. It helps us to know the anatomy, the structure of the entry point, and the segment of the the CTO segment. And with the help of the bilateral injection, also the HDR technique help us to see the entry point, the microchannel, and etc. And iris, the iris help us to know the cap to get the cap puncture and the wear position and the position of the re-entry to minimize the segment of subintimal. And integrate techniques extend to HDR, TDADR, and 3D wiring and iris ATS techniques. And we hope to achieve the shot as much as possible to re-entry in the subintimal to replace the long segment subintimal tracking, and retrograde reserved for defined anatomy, and conventional ADR technique, which means the steering wheel assists the ADR and moves from the pillar to a select build-out strategy. In 2022, your invention published a review article and summarized the history of CTO technique. CTO technique have about a 50 years history and now, and a lot of technique and device improvement and algorithm improvement also. And in 2021, global CTO crossing algorithm have published in JACC Intervention. And Professor Li Yue also one of the writing group. And in this version of the algorithm, and also emphasize the importance of intracoronary imaging. So from the from the start, and iris could help us to identify the entry point, and using after the failure of the integrated wiring, also used iris facilitates the parallel wiring could improve the success rate. Even after that, and iris guided the re-entry, subintimal re-entry also can limit the segment, the length of the subintimal space. And what's the difference between the global algorithm and the other algorithm is improve the role of the CT scan before the CTO procedure, and also use the errors not only from the proximal the integrated strategy, also the retrograde strategy in the whole procedure to guide the PCI and improve the long-term outcomes. And for the global algorithm, and because of the improvement of the integrated strategy, including HDR, 3D varying, and TD-ADR, and AWE strategy preferred for all of this CTO procedure. But the RWE, the retrograde strategy, only for the lens, the very diffuse lens, the severe calcification, and ambiguous vessel cause, and after the failure of the antigrade wiring. And for now, antigrade strategy is no longer just antigrade wire escalation. It including a spectrum of antigrade tools between simple wiring and switch to retrograde approach. From the simple case, we can use the average guided puncture, and we can use the average guided wiring and re-entry. And for the complex case, we can use the TD-ADR, HDR, TD-HDR, and other kinds of the target re-entry techniques. By the errors and by the improvement of the device, and use the more advanced antigrade technique, we can improve the successful rate of the antigrade wiring. And for the errors guided, this is the traditional using errors. We can use the proximal set branch to place the errors catheter to help us to find ambiguous and proximal cap, and use the TD-ADR and the tip detection puncture combined with the contrast. We can improve the efficiency and the success rate of the antigrade wiring. And this example, and we can see from the errors and the average catheter from the set branch can clearly see the wiring already penetrates successfully in the plaque, in the entry point of the CTO case. And this is the technique of the iris ATS. This means the iris facilitates the active anti-grid true lumen seeking, and not only from like the traditional using the iris seeking the proximal entry point from the set branch. Also, when the parallel wiring both filter and into the subintimal space, and we can use the iris catheter in the wiring subintimal, and we can guide it by these errors. We use another penetrated wire just at the segment of the wiring outside the true lumen into the subintimal, and we just control the length of the subintimal space, and just penetrate the plaque at the site of the plaque, intraplaque and subintimal segment, and finally we can time to time untimely and see the wire into the plaque and identify the position of the wire. And Professor Tong Yaliang also improved this technique. We call it the pro version of the iris ATS. It have 4S per simple in iris ATS technique, which means the seeking entry point, and the stick the plaque, and the swap and the de-escalation the gate wire to a more subtle gate wire, and seek the microchannel, and finally achieve the recognition of the CTO case. And this is 3D wiring by the Japanese expert, and which means there's a tip detection anti-grid wiring, and TDA anti-grid wiring, and dissectory entry TD-ADR technique. And by the iris guidance, the TD-ADR technique make it possible to accurately navigate the guided wire to the target in the real time, not only where the intraplaque route, but also when the guided wire go into the suboptimal space, it can guide it as re-entry the route in CTO PCI. So this technique is also improvement from the 2010 to 2021. It can improve the success rate of anti-grid wiring by the hours. And it already established a 3D wiring into CTU PCI. And this also start after the parallel wiring failure into the suboptimal space. And by the guidance of hours, they're using another penetrated wiring, usually CP or CP12 to penetrate the plaque. And usually in the hours, we can see the three situations, including the clockwise, or the counterclockwise, or the undecided. If the undecided the direction, we can pull back a little and clockwise turn the direction of the wire. And finally, the 3D wiring, this technique can help us to timely observe the tip of the guide wire, and it's essential for the average guided 3D wiring technique. And HDR is also importantly proven of the CTO PCI case. It's a contrast modulating technique to facilitate a crossing of the occipital vessel. It's using a contrast first principle, not like the Carlino technique. It can actively before the wire has failure to go into the suboptimal space. They have three key steps, which means the cap puncture and contrast macro injection and polymer jacket wire parsing. What's the difference? This table shows there was a difference between ADR and the classic Carlino techniques. And the HDR technique is the upfront techniques compared with the Carlino, which means the late often the last result, and the successful rate is low. And the contrast volume is also very small, only less than 0.5 microliters. And the force of the injection is very soft. And this example is a LED occlusion, and the Gaia 2-second has penetrated into the proximal entry point and use this HDR technique less than 0.5 microliters. We can clearly see the CTO segment, and after that, it advanced software, usually polymer jacket, where you can cross the lesion. This means using the contrast, minimalized contrast to show the root, to show the segment of the CTO case, and to make this tissue softer and easy to parse using the polymer jacket wire. And earliest data have shown that the successful rate of this HDR technique is very high compared with the traditional Carlino technique. And Professor Ru from China also developed a special device for this technique. They call it titration contrast recanalization, TCR. It's a modern technique of the HDR. It can help us to standardize the using of this HDR technique. It can limit the injection force of the operator and limited the contrast injury of the artery and improve the successful rate. And this technique is a TD-HDR, TB detection puncture and hydrodynamic contrast recanalization. And they combined integration two techniques, hours guided technique and HDR technique. And after the hours guidance, confirmed the entry point and using the contrast, also minimize contrast injection to show the root of the CTO segment, and also improve the successful rate. And after we talk a lot about the improvement, integrate improvement, the retrograde also very important. But in nowadays, the strategy, the technique of the retrograde not improved very much, but a lot of the device improvement, including the wiring, the crossing channel technique, and the microcatheter is improvement. And for now, for current algorithm comparing the antegrade and retrograde, which one should prefer? For the if the proximal cap appropriate for our receptor for iris guidance, we have the acceptable distal target, the occlusion is short, our focal, and now safe, now good collateral. And if the operator familiar with the iris TST technique, TDADR, and HDR, and we think the antegrade first is favorable. And if the patient the lesion have the ambiguous cap and the protostal target, the long diffuse calcified lesion, and also the patient have excellent safe collaterals, and the anatomy predict antegrade failure up front, and this patient we prefer to retrograde first. And for the ADR, and conventional ADR its role have declined for the current based on the current techniques. The big problem of the current ADR technique is the uncontrolled subintimal space, and sting rate dependent ADR is being repositioned, no longer a default pillar. And what we recommend using the current ADR is all the proximal the antegrade technique failure, and if the patient have not acceptable retrograde channel, or the retrograde also failure, and we can also use ADR. But even for this time, we have to think about the limited. The first limited the subintimal space. Not have if we have a very long subintimal space and we lost a lot big side branch vessel, and the outcome will be not good. And this table shows the difference between the conventional device facilitated ADR and the current contemporary antegrade wiring. Like what we just introduced, the TDADR, average ATS, or TDHDR technique. And the most important difference is the limited segment length of the subintimal space. And from my view, update CTO hybrid algorithm in 2026 is based on the imaging, including the dural injection, angio, and CT before the procedure, and iris lesion assessment, including to help the operator to know the anatomy of the proximal cap, distal target, collateral, the length, and the classification of CTO case. And if the patient has feasible anatomy, and integrate first always. And if the CTO lesion is very diffuse, very calcified, and ambiguous cap, and the patient also have interventional acceptable retrograde channel, and the retrograde will be preferred. And conventional device ADR had declined to a selected bailout strategy for the current procedure. And we also the operator should consider the safety and what time to stop. And if the procedure time exceeds 3 hours and contrast approaching the 3.7 times of EGFR, and air camera greater than 5 gray unless procedure is well advanced and not progress after complete well-executed strategy, and the operator should consider to stop. And if the operator should commit early to a plan, but switch device when it falls, and using imaging every time from the beginning to decide the next move, not just to confirm the wear position, and don't be stuck in a failure mode in a single approach. Which means you should switch your strategy, not only integrate but also retrograde and ADR as a bailout. And finally, as a summary, the CTO PCI in 2036 is imaging informed and algorithm flexible with appropriate strategy switching based on the bilateral age OCT IVERS guidance. And integrated strategy have expanded beyond simple wear escalation, including the IVERS ATS, TD-ADR, HDR, and TD-HDR, etc. And retrograde remains indispensable. But anatomy and we have to know that it's anatomy and risk-driven. It's preferred for those lesions with ambiguous caps, poor targets, diffuse calcification, and good collaterals. And conventional device ADR, which means Stingray, maybe no longer as a default pillar, is the repositioned as a selected bailout. And compared with the target IVERS guided reentry, we think it's the modern evolution, maybe in the more important in the future. Thank you.
Okay, thank you, Professor Song Li. Thank you very much for your excellent lecture and excellent technique and wonderful cases. So because of time limitation, we could discuss later. And next, please allow me to invite next speaker is Professor Chen-Chi Yang from National Heart Center, Singapore. Welcome, Professor Chen.
Thank you. Okay. I assume you can see my slideshow.
Yeah.
So my topic is going to be on managing. So my topic is going to be on managing calcified lesions, including the devices that are available to us and some of the evidence behind them. So I think we all know that the incidence and the prevalence of calcium amongst our patients nowadays is not low. A lot of our patients are getting older, they are more aged, and a lot of our PCI cases involve some form of calcification. And in this observational kind of study, it was reported that up to 73% of patients actually were found to have calcification on intravascular imaging during PCI. Now, challenges of PCI in lesions which are calcific, I think this is all well known to anyone who has been a PCI operator. Calcium increases our procedural complexity, it increases procedural risks, complications, and we get it is harder for us to get a good result after PCI in a heavily calcified lesion. We get suboptimal acute PCI results, such as stent under expansion. Sometimes we have residual dissections, etc. And of course, there's increased long-term target lesion failure as well associated with PCI for calcium. So many strategies exist for the management of calcium. This is just one of the recommendations. This is from the SKY group. So this is their expert consensus statement for the management of calcified coronary lesions. And I'm sure this is familiar to most of you, but I just want to highlight the importance here. This really is the second step after angiography. This is the first step of the PCI, which is the intravascular imaging element. And with intravascular imaging, if it is done and we are able to get the information from that, then we can tailor our treatment according to what we see. And we'll go through the rest of the algorithm later. Okay, so the first speaker in this session has already spoken about the appearances of calcium on imaging, so I'm just going to go through this very quickly. On IVUS, as we all know, calcium tends to reflect all the ultrasound waves, And therefore, we see a very bright signal at the surface of the calcium, but we don't see anything behind because none of the ultrasound waves are able to cross or go through the calcium. And this is the main difference between the appearance of calcium on IVUS and OCT. On OCT, light is able to penetrate through calcium, and we are therefore able to see not just the leading edge of the calcium, but also the deep edge of the calcium as well in some cases, such as here. And of course, this means that when we assess calcium by OCT, we can determine the thickness of calcium, whereas on IVUS, we often are not sure how thick the calcium might be. So a few calcium, there are two calcium scores that exist based on intravascular imaging, one for OCT and one for IVUS. This is the updated or the newer OCT calcium score, where they now use the rule of threes instead of the rule of fives. So according to the rule of threes, if you have the appearance of calcium that is more than 3 quadrants in circumference, and for more than 3 millimeters of length, that's 1 point. If at any point you have 360 degrees calcium, that's 1 point. And if you have a minimum calcium thickness of more than 0.3 millimeters, that is another point. And on this OCT calcium score, if you have at least 2 of these elements, then you can expect that your stent expansion is going to be poorer, and you should therefore consider calcium modification. So a similar thing for IVUS. Again, the score is according to the appearance of calcium on imaging. So again, more than 270 degrees arc of calcium, any point where there's 360 degrees concentric calcium, if there's the presence of calcified nodule, or if the vessel diameter is less than 3.5, each of these gives you a point. And if your calcium score is 2 or above, then you are more likely to have underexpansion if you don't use atherectomy compared to if you were to use atherectomy. So the higher the calcium score, the more aggressive you should be with your lesion preparation. So calcium distribution on imaging, so it's not just about the calcium score. After the calcium score, the way you analyze the imaging also can influence your PCI strategy. So here are a few examples of different types of distribution of calcium. So in the first example here in A, you have a circumferential kind of calcium. And this is the kind of calcium that is perhaps more suited for atherectomy, be it rotational atherectomy or orbital atherectomy. In example B, there is also calcium. It's to one side of the artery, but between the calcium and the lumen, there is thickness. There is a thick layer of fibrous tissue. So in this kind of situation, if you were to choose atherectomy, it may the atherectomy burr will have to go through the fibrous plaque before it can affect the calcium. So in this situation, perhaps atherectomy might not be your first choice device, and you can try with a balloon-based device. In example C, although there's calcium seemingly around the whole vessel, but this calcium looks to be interrupted. So there are gaps or there are cracks already along in between the calcium plates. So in this situation, a balloon expansion may be successful, and you might be able to stretch the artery open just with a normal balloon. And finally, eccentric calcification, which is usually very tricky to deal with in this situation. If you use a big balloon, then you risk perforating the normal part of the vessel before you can affect the calcium. So in this kind of situation, you might want to consider a very careful atherectomy or perhaps intravascular lithotripsy. How else can imaging help us in our PCI for calcium? IVUS can sometimes predict slow flow after rota. So in this study, factors associated with slow flow after rotational atherectomy was if the lesion length was more than 24 millimeters, if there were a lot of reverberations on the pre-PCI IVUS interrogation, or if the arc of calcification was more than 300 degrees. The more of these elements you have, then the higher chance of slow flow after rotational atherectomy. What about vessel injury after atherectomy? This was a study that described the potential complication of perforation or vessel injury after orbital atherectomy. And according to the pre-PCI imaging, if you see that the normal vessel comes into contact with the imaging core at an angle of more than 92 degrees, then that seems to predict a higher chance of vessel injury after orbital atherectomy. This was just a case example from one of my friends, Dr. Kuramitsu. So in this case, he used rotational atherectomy after IVUS interrogation, and after rotational atherectomy, big hematoma developed. And when he went back to examine the pre-PCI IVUS features, he saw this so-called tenting sign, which called it the tenting sign, where you see the vessel, again, the normal part of the vessel seems to be stretched by the IVUS catheter. And as a result, during rotational atherectomy, it caused injury in that normal part of the vessel. Just quickly show you an example of a case from my own hospital, similar, which came across a similar complication. So our target lesion was here in the bifurcation. In this case, we did OCT and then orbital atherectomy. So before lesion preparation, we had this appearance. Again, at that time, we didn't recognize this. But after orbital atherectomy and balloon dilatation, we had this very odd kind of appearance where the OCT catheter now appears to be in a false channel. So we suspect what happened was that initially the OCT catheter was in the true lumen, but after atherectomy, the atherectomy caused there to be a false lumen, and then the subsequent imaging run shows the OCT catheter in the false lumen. So luckily for us, this was just a contained perforation rather than an uncontained one. And after stenting on the LAO view here on the right, you can see that there's clearly a big pouch of contrast. We did OCT at that point. So this is the OCT pullback after stenting. And the stent, maybe I find a frame that's clearer. The stent is here. And all this space outside the stent is the contained perforation. So this looks like a very bad injury. We tried balloon tamponade for a few minutes, but I think this was never going to seal with just tamponade alone. So we had to implant a short covered stent to exclude this perforated cavity. So yeah. So that's just to say again that OCT or imaging before PCI, before atherectomy, can help to predict injury. Okay, so after we do atherectomy, how do we know that we've done a good enough job? These are some of the findings that we that we would like to see. We want to see increased reverberations after atherectomy. So in this example, the same segment before and after rotational atherectomy, there's an increase in reverberations. Of course, if it's possible to identify calcium cracks, which sometimes you don't see, but if you see calcium cracks, then that's of course a good sign. Here's another example of a case where there's distal left main disease, very calcified vessel, and then there's some LAD disease there as well. So the pre-PCI IVUS interrogation identified that there were areas of concentric calcification here in the distal left main, as well as the bifurcation of the circumflex and the high diagonal. And you can see that the wire bias of the imaging catheter appears to be quite favorable here for atherectomy. So in this case, we went with a 1.5 and 1.75 millimeter burr, and this was the angio after atherectomy. And this was the IVUS findings after atherectomy, where we can see that there has been some debulking, where the rotational atherectomy burr seems to have taken a bite out of the calcium. We've got some luminal gain and areas of cracks as well as reverberations. So in this case, it was completed with stenting, which was quite straightforward. Sometimes we have to combine strategies, so atherectomy plus lithotripsy, in order to gain, in order to have two of the benefits, yeah? So with atherectomy, we can debulk the lesion. We can create a path for our bulkier devices to go through. And of course, with a balloon angioplasty and lithotripsy, we can get a little bit more luminal gain than just with atherectomy alone. This is a case. This is the RCA. So the RCA has quite severe disease in the proximal to mid segment. Distally, some disease as well. And also on the LAD, there's a calcification here in the proximal to mid LAD. So this patient declined bypass surgery, so we proceeded with PCI. So we tried to, so I attempted the LAD first, and as you can see, the IVUS catheter would not cross that tight lesion. So that already is a sign. So at this point, there are, I guess, really only two options. Maybe try a small balloon to make some space, or we can go with upfront atherectomy. I think IVL will never cross this lesion. In this case, I opted to go with atherectomy, tried with the 1.5 millimeter burr that did not cross. So I had to downsize to 1.25, and it finally crossed after a few runs. Upsized it back to the 1.5. This is the angiogram after. And after rotational atherectomy, the IVUS could cross quite easily. And so we did the IVUS after rotational atherectomy. And here we see the calcium, and there will be a spot somewhere around here where there's concentric calcification. So around here, there's concentric calcification in this lesion. Again, options would be just to go with a bigger NC balloon. In this case, I wanted to try this new intravascular lithotripsy balloon that we had in our lab. So this was the 330 by 12 millimeter sonic cracker IVL. It inflated quite well, and after 80 pulses, this was the result that we got. And imaging post-rota revealed some of these cracks. Imaging post-IVL gave us these cracks which were not there before rota. Okay, and then we just finished the case with Scoreflex and stent. And then we moved on to the right. This was the right coronary artery of the same patient. And I thought initially that we would need to do the same thing, perhaps rota, perhaps some IVL again. But this time the IVUS IVUS catheter could cross easily. And this is the IVUS assessment of the RCA. We see some eccentric calcium there. And then around here is the tightest part of the vessel. But what we can see from here is that most of the calcium seems to be deep. Although the lumen is tight, there's a lot of fibrous tissue. So it's deep calcification, and it's also quite interrupted. So it's not one fixed, one solid plate of calcification. So based on this appearance, I thought that perhaps we could try a balloon dilatation strategy. So just with scoring balloons, we managed to get reasonable balloon expansion. Then we implanted the stent. We got a final result, which was quite okay. So we've managed to avoid doing anything more aggressive than just balloon dilatation. So you saw a few strategies for how to approach calcific lesions, but did any of what I just showed you have any strong evidence-based? The answer, unfortunately, is not really. So these are some studies on the use of rotational atherectomy. So with rota, we can get a little bit more success with our procedure because rota can help us sometimes make space for the uncrossable lesions before we advance our balloons. But if we're talking about improved long-term outcomes, so far there's no good study that has shown that any of these strategies do result in a better long-term result. In terms of the different types of balloons, cutting balloon after rota versus just a normal NC balloon in this rota cut trial. Again, unfortunately, no benefit in using a cutting balloon after rota as compared to just a normal NC balloon. So NC balloon was able to achieve just as good MSA after rota. In the ECLIPSE trial that was presented last year at TCT, this looked at orbital atherectomy versus just balloon-based vessel preparation. And again, as you can see, the curves are very close together. So OAS the routine use of OAS didn't seem to result in improved MSA or even target vessel failure compared to balloon preparation alone. Funnily enough, or interestingly enough, in a sub-study of the ECLIPSE trial, of the same trial that looked at the use of intravascular imaging guidance, in the patients where intravascular imaging was used, there was an improvement in results. So they did have less target vessel failure. So this shows that the use of intravascular imaging can help us improve outcomes, even though the actual strategy of orbital versus balloon failed to achieve any significant result. And then other trials, cutting balloon versus IVL or OPN versus IVL, again, results very similar. So cutting balloon was non-inferior to IVL, OPN was non-inferior to IVL. So this really makes us kind of have to consider whether a lot of these new devices, which a lot of them are very expensive, whether we need to really use them in every case or not. So in summary, I think heavily calcified lesions remain one of the biggest challenges in contemporary PCI. There are a lot of strategies, as I've shown, and many calcium modification tools. Although so far there's no, good evidence that one is really much better than the other and leads to better long-term outcomes for the patients. However, intravascular imaging, I think it's got to be mentioned. It's been mentioned a few times during this session already. Numerous trials have shown the benefits of intravascular imaging in complex PCI, including calcified anatomies. I think imaging really should be used. So as a takeaway, perhaps we can say that many calcium modification devices exist, and the choice of which one to use should be made case by case. Yeah, the lack of evidence doesn't mean that we shouldn't use any of them at all. And preferably we should use intravascular imaging to guide our PCI where possible. Okay, thank you very much.
Okay, thank you very much, Professor Qi Yang, for your excellent lecture. Very sorry because of the time limitation. Let's invite the last speaker of the session, Professor Ye Fei from Nanjing First Hospital. His topic is portal techniques in retrograde CTO PCI, simplifying procedures without externalization. Welcome, Professor Ye.
Thank you, Chairman. Professor Lee, I share my presentation here. So, I don't know.
Yeah, we can see your slide.
Yes, but I cannot move it. I'm sorry. Yes. So the topic is portal tactic in retrograde CTO PCI, simplifying procedure without externalization. I'm Dr. Ye Fei from Nanjing First Hospital. So as we know, the CTO is still challenging in daily practice in our CAS lab. Retrograde microcaster combined with antegrade microcaster, as Dr. Song Lei said previously, has significantly improved the total success rate of CTO PCI procedure. Guide wire externalization is commonly performed during traditional retrograde CTO PCI. However, it requires advancing the retrograde microcaster into the antegrade guiding caster, which can be challenging in cases of heavy calcification or very total CTO body, or when advancing microcaster through very totals or small collaterals. These difficulties can result in complications such as microcaster entrapment, collateral vessel injury, even collateral vessel perforation. So, two solutions to overcome this challenge. One is trapping retrograde wire inside the antegrade guiding caster, or slurring the retrograde wire in the ascending aorta with catch-it maneuver in antegrade guiding caster. So the concept of portal tactic is a new concept that combined a lot of tactics during the retrograde wire tactic. The tip-in and the run-out tactics are the two main options for avoiding externalization by achieving a retrograde connection followed by an antegrade conversion. More variation approaches focus on wiring and sharing the objective in intubating the distal tip of an microcaster, balloon, or stand with antegrade or retrograde guide wire, which may reduce the risk of complications by avoiding tension on fragile collaterals during the externalization and avoiding collateral injury or perforation. Recently, a new term named portal tactic, which means collectively summarize all these methods like tip-in or run-out or other facilitated tip-in or catch-it, etc. All these methods that have common the transportation of a guide wire through a portal represented by a distal tip of multiple devices, just like guiding casters, guide extension, or microcasters, or balloon or stents, to make the connection and ultimately integrate the conversion without externalization. So we will describe all these methods one by one in detail. So first is a tipping technique. The tipping technique involves intubating an integrated microcaster with retrograde wire that has successfully crossed the CTO body and entering into the integrated guiding caster. Subsequently, the integrated microcaster is advanced over the retrograde wire through the CTO body to the distal true lumen. The retrograde wire is removed, allowing the advance of an integrated workhouse wire over which PCI is performed. The tipping technique indication showed that there is two. One is the retrograde wire success cross the CTO body into the integrated guiding caster, but the retrograde microcaster failed to cross the CTO body. The second is when the retrograde wire successfully crosses into the integrated guiding caster, the advancement of retrograde microcaster is considered to carry high risk for collateral channel injury, especially when we met some collateral channel was very small or very total or very long. The tipping technique description showed the picture here. The left A showed that the connection can be made at any points when in the guiding extension, highlighting just like here, the yellow segment here for the tipping technique performed when we perform the guiding extension to push into the coronary artery. The plan B. So it's quite I'm sorry. Often in my daily practice for here, the tip of the retrograde wire makes the green dot here, just like picture A showed that there is two drop picture here. There's two side of outer curve of the guiding caster. It's the good position for the tipping here. So the plan B showed the tip of the retrograde wire marked by the green dot and the tip of integrated microcaster just located at the same place here. So we can make the connection here, the good position here. The plan C showed balloon assist if the integrated microcaster was not stable. Well, just because we find the phenomena of the microcaster was moved forward or backward very according to the heartbeat. So we will use balloon assist to stop the integrated microcaster move forward and back and more stable here. So we can make tip in with balloon assist here. The tipping technique troubleshooting for successful guiding wire cross into the microcaster tip, movement should be precise and gentle. Contact is very important. We can see the wire or contact with the tip of the microcaster. We have find the retrograde wire tip blocks against the microcaster and slightly rotating. We can successfully push the retrograde wire into the integrated microcaster. So if manual resistant feedback is another very important phenomenon. If we push the retrograde wire meet the integrated wire, we will find some manual resistance just because we will pre-location integrated wire position the 3 to 5 millimeter proximate to the integrated microcaster tip. It's very important phenomenon. So failure often results from poor coaxial alignment, which can be corrected by adjustment microcaster tip position or shape the retrograde wire with a 60-degree bend 2 or 3 millimeter from the tip, or we can reshape the integrated wire tip, or we can use a catch-up technique with another super support wire to make the integrated wire back microcaster tip a little bent. This is the case in our heart center. This is proximal RCA total occluded after retrograde wire going to the integrated guiding extension with the AGT tactic. We will find that the second picture showed that we push the retrograde wire into the integrated microcast easily during the out curve site of the integrated guiding caster. So this is the final result. It's very good. So tipping tactic, we should a lot of troubleshooting tactic. The manual microcaster tip modification for precise steering towards the shaft of the reshaped microcaster is a very useful experience when we cannot contact with the retrograde wire to the integrated microcaster tip. The hula hoop tactic using a band guide wire back and to enhance microcaster tip control. So the third is position a small balloon, just like 2.0 or 2.5 near the microcaster tip to align it more closer with the guiding caster out curve and make the integrated guiding microcaster stable. To remove the unnecessary equipment from the guiding caster to better determine whether the retrograde wire is on the left or right side to make sure the retrograde wire can control easily. To increase X-ray magnification and collimation to improve visibility. The ping-pong technique in case of using a separate guiding caster for the connection through an epilepsy collateral. Another, after tipping tactic, we should push the integrated market crossing the CTO region. If we met some problem or make some resistance when we push the integrated microcaster across the CTO region. So we have a lot of methods to resolve this problem. So first, preloading the integrated microcaster with guiding extension or support. Using a more support integrated guide wire or its back end facilitate tipping tactic. Tipping the integrated guide wire in the retrograde guiding caster, reverse wire trapping. The fourth is advancing supported retrograde wire deep into the integrated microcaster as far as possible. The longer the better. The switching to the tip-in balloon tactic and enlarge the extra black space with a further additional balloon angioplasty wire. We should maintain the integrated microcaster stable. We cannot move out the integrated wire microcaster if it is possible. Simultaneously push and pull tactic, slowly pulling the retrograde wire, pushing the integrated microcaster with two operators can maybe better. So we should know if we perform a tipping tactic, we should know difference between the various microcasters, especially for the tip, inner diameter and out diameter, especially for the inner diameter and different microcaster. Even though we also can use a different microcaster, but crossability was not equally. So facilitate tip-in tactic overview, and this is another changed tip-in tactic, the similar. This is an enhancement of a traditional tip-in tactic designed to increase support of integrated microcaster using the back end of a workhorse or workhorse guide wire to improve support when the integrated microcaster fails to cross the CTO region on the retrograde wire. So facilitate, just like a picture shows that here we use the back end of the workhorse wire to make just little bend and push into the integrated microcaster. Care must be taken to prevent the guide wire from the existing the integrate the guiding caster into the coronary artery just because the back end was very, very stiff and make the coronary artery injury. So just because this part of the wire was long radial plaque, so we cannot see it clearly from the X-ray and it can be difficult see it. So bending helps us identify the guide wire near the microcaster exit, but spinning the microcaster can be cumbersome. Alternative, a stiff body guide wire can exchange to the back end of the workhorse wire, just like we can use extra support grand stem to exchange the back end of the wire. It should be safer. So another interesting biting technique introduced by Zhao Ling in Beijing. And the conventional tipping technique has been replaced by advancing an integrated microcaster through the guiding extension system with moderate rotation. Allow it to capture. It's just like captures fish, and allowing capture the retrograde wire like a fish biting a hook without manipulation. Then it allows the integrated microcaster to traverse the occluded segment along the retrograde wire to facilitate microcaster passage. So tipping technique can technically challenge during the limitation of control over retrograde wire manipulation for the reason of totals or long collateral channels or heavy calcification or retrograde wire was clamped by the retrograde thin wall microcaster. So during our practice, even we met some very long and totals collaterals, we cannot not control the retrograde wire compared with the antegrade wire technique. So at that time, we can use a bite-in technique. This is our case. It's also RCA total occluded. When the antegrade failed, so we perform a retrograde wire technique after retrograde wire. So after wire control into the antegrade guiding caster, we cannot control the retrograde wire smoothly. So the tip of the retrograde wire cannot move. So we use a bite-in technique with fine cross at the outside curve here. Push into the antegrade microcaster to catch the retrograde wire easily and cross. After that, this is the final result after we perform PCI antegradely. So tipping balloon. A lot of times we use a tipping microcaster. Sometimes we use a tipping balloon. So tipping balloon technique used as a conventional integrated coronary balloon instead of a microcaster for performing the tipping maneuver over the retrograde wire, allowing the predict progress to the PCI of the CTO lesion. So when the guide wire externalization is not designed, for example, when cross epicardial collateral or when externalization guide wire is not available, and when failing to cross a CTO body with the integrated microcaster after successful tip-in microcaster technique, all the other indications of tipping technique. So we can perform a tipping balloon to perform a pre-dilate with a smallest profile of the balloon. Tipping balloon technique with multiple attempts may need successful tipping with a balloon if entry is difficult with a smaller balloon. First, in my daily practice, I will use the smallest balloon with 1 over 0.75 millimeter balloon to tipping balloon technique to perform tipping balloon technique to pre-dilate the CTO lesion. Then we can perform tipping microcaster easily. Maybe challenging is intubating the balloon tip may arise due to the retrograde wire shape or limited torqueability. So another solution should be to inflate the balloon at 4 atmosphere inside the guide caster to display the balloon tip for the caster wall facilitate it to intubate with a retrograde wire, just because maybe we cannot, we also can reshape the tip of the balloon, but more active maybe use a microcaster. Unlike a microcaster, balloon caster lack a distal mark, complicated precise positioning of the tip. Estimate the tip of location from the distal balloon mark can be facilitated using a workhorse wire inside of the balloon, and a limitation of this tip is that it needs a passage of an antegrade wire after initial lesion dilatation. So it's quite important. We also can use a workhorse wire to near the insert it into the antegrade balloon more just a little. We cannot push out. So another is antegrade microcaster probing, and after retrograde wire crossing, the retrograde microcaster is advanced into the antegrade guiding caster, followed by removal of a retrograde wire and intubating of a microcaster with an antegrade wire for rapid antegrade conversion. So when the guide wire externalization is not desired, for example, when the crossing epicardial collaterals, when externalization guide wire is not available to avoid a second microcaster within the same guiding in epilepsy, retrograde CTO PCR, or to save a second microcaster in a minimalistic approach. So we MP antegrade microcaster probing is not a solution for initial scenario of a retrograde device uncrossable lesion. However, its performance is similar to the other tactic presenting tipping tactic, avoiding externalization, and significantly reduce the time for antegrade conversion. After removing the retrograde wire, support for the retrograde microcaster is reduced and may result in a retraction of retrograde microcaster from the antegrade guide into the vessel. Thus, this is important to either advance the retrograde microcaster far enough into the antegrade guiding caster, or trap it when with an antegrade balloon. And we should consider leaving the retrograde wire inside the microcaster 10 centimeters from the tip of the microcaster. So there is two advantages. One is to make the retrograde microcaster more stable in the antegrade guiding caster. And if antegrade wire encounters the resistance in the retrograde microcaster, it can be confirmed that the tactic has been success. There is different tipping tactic. The left up is a tipping balloon tactic. We can perform this tactic in the outside, in maybe in the guiding caster, in the roof. The tipping stand, we also can perform this tactic in the guiding caster. So typical antegrade microcaster probing tactic, we also can use this. Like tipping tactic, we use antegrade wiring into the retrograde microcaster in the outside curve in the guiding caster. So the second serious tactic is a Randall tactic. Traditional Randall tactic is involving inserting an antegrade guide wire from the antegrade microcaster into the retrograde microcaster. Traditional perform inside the antegrade guiding caster. The term Randall is generally using when the intubating point is inside in the CTO. We have two Randall tactics. One is in the guiding caster, another in the CTO body. When both retrograde guide wire and the microcaster can be advanced inside the antegrade guiding caster, it's easier to initially attempt antegrade microcaster probing or tipping. When the retrograde microcatheter fails to cross the CTO segment, and the retrograde wire cannot be intubated into the antegrade guiding catheter or guiding extension. When the antegrade microcatheter is very close to the retrograde microcatheter, we can perform a Randall technique. Just like this, left picture shows that a traditional Randall technique performed in the guiding catheter.
So yeah, you have 1 minute.
Okay, I tried. The one is in the guiding catheter, left is in the CTO body. And the Randall tactical troubleshooting, we should make sure both retrograde and antegrade microcatheter touch it closely. It's quite easy. Another modified Randall tactic, the tracing wire tactic in the CTO body with push and pull back the retrograde and antegrade wire to make the both guiding microcatheter deep closer. Deep dive random mode is another, just because time is limited. I just want to use make the retrograde wire, antegrade wire more distal to make sure the more supported from here. So catch up is another technique with if we cannot to push the retrograde wire into the antegrade wire guiding catheter, so we can perform this technique in the aortic or the subclavian artery. So this is the agent for the application of a portrait technique. We can, if we retrograde wire technique, we can use externalization, AMP, tipping, retrograde, reverse cut, Randall technique, etc. So I will summarize for my presentation here. Portrait technique offers significant advantage by promoting a unit approach that integrates both retro and anti technique. This strategy allows the anti-retro gear to interact via guide wires, providing operator with a device set of solution and variation. This technique not only expand the operator skills, but also enable more precise and adept approach to tailored to specific challenge of each patient. Thank you. Thank you for your attention.
Okay, thank you, Professor. Yes, thank you very much for your wonderful lecture and wonderful techniques. Show us many tips and tricks in how to use all these techniques. Because of time limitation, we only have 5 minutes. Professor Li Yongle, one short question.
Thank you, Professor Li Yue. Thank you, Professor Yefei. Give us a very excellent practical presentation. I have a question for Professor Yefei. In your experience, which portal technique is the most practical and reproducible for routine clinical use? Thank you.
Thank you. In my practice, the most portrait technique is tipping. Tipping is maybe 80% for my daily practice when we perform a retrograde wire technique. Thank you.
Okay, any other questions? So one short question is for Professor Kassam. So as we know that in this year, March, two very important study called IWAS CHIP and optimal study, both reported neutral results for imaging-guided PCI in complex and left main lesions. So, and this seems inconsistent with earlier positive trials, such as the runaway trials like you introduced. So my question is, how do you reconcile these conflicting findings? Professor Kassam?
Thank you, Professor Lee. Yes, there is some conflicting data, especially from for also trial showing this conflict results. But actually, we can explain this by the spectrum of lesion in these cases. This case this is not selected a complex lesion only. It is using and dedicated for a wide spectrum of lesion. So the results may be comparable in this study. But in this study I presented today, the Renovate, it is dedicated mainly for the complex lesion. So it is clearly showing in this study that the more the complex lesion, the more the impact of image-guided PCI results in prevention of any complication and the impact in long-term target vessel failure.
Okay, thank you very much. And because of time limitation, and we have to stop here. And I do think we have had a successful session with excellent talks and warm exchange of ideas. And I would like to express my sincere gratitude to all the speakers for your wonderful lectures, and gratitude to all the moderators, Professor Yahaya, Professor Li Yongle, for your wonderful comments. So I think we have to stop here, and see you next time. Bye-bye.